Hello, students. Today's topic of our lecture is pulmonary failure and chronic pulmonary heart. Cor pulmonale is defined as an alteration in the structure and function of the right ventricle caused by a primary disorder of the respiratory system. Cor pulmonale usually present chronically, but two main conditions can cause acute cor pulmonale: pulmonary embolism and acute respiratory distress syndrome. The underlying pathophysiology in massive pulmonary embolism causing cor pulmonale is the sudden increase in pulmonary resistance. In ARDS, two factors cause right ventricle overload. The pathologic features of the syndrome itself and mechanical ventilation. Ventilation, especially higher tidal volume, requires a higher transpulmonary pressure. In chronic cor pulmonale, right ventricle hypertrophy generally predominates. In acute cor pulmonale, right ventricle dilatation mainly occurs. In the case of ARDS, cor pulmonale is associated with increased possibility of right to left shunt through the patient foramen ovale and carries a poorer diagnosis. Pathogenetic mechanisms. Several different pathophysiologic mechanisms can lead to pulmonary hypertension and subsequently for cor pulmonale. These pathogenic mechanisms include the following: pulmonary vasoconstriction due to overload hypoxia or blood acidemia. This can result in pulmonary hypertension, and if the hypertension is severe enough, it causes cor pulmonale. Anatomic compromise of the pulmonary vascular bed secondary to parenchymal of alveolar lung disorders, adult respiratory distress syndrome, and rheumatoid disorders. These conditions can cause elevated pulmonary blood pressure. Chronic obstructive pulmonary disorder is the most common cause of cor pulmonale, and some connective tissue disorders with pulmonary involvement may result in pulmonary hypertension and cor pulmonale. Increased blood viscosity secondary to blood disorders. Increased blood flow in pulmonary vasculature. Idiopathic primary pulmonary hypertension. The result of the above mechanisms is increased pulmonary arterial pressure. Right and left ventricle output. The right ventricle is a thin-walled chamber that is a better volume pump than a pressure pump. It's better suited to adapt to changing preloads and afterload. With an increase in afterloads, right ventricle systolic pressure is increased to maintain the circulatory gradient. At a critical point, a further increase in pulmonary arterial pressure and resistance produce significant right ventricle dilatation. An increase in right ventricle and diastolic pressure and right ventricle circulatory failure. A decrease in right ventricle output leads to a decrease in left ventricle filling, which result in decreased cardiac output. Because the right coronary artery originates from the aorta, decreased left ventricle output causes decreased right coronary blood flow and ischemia to the right ventricle wall. What ensures is a vicious cycle between decrease in left ventricle and right ventricle output. Genetic investigations have confirmed that morphogenesis of the right and left ventricle originated from different sets of progenitor cells. Their differing embryologic origins could explain the differing rates of hypertrophy of the right and left ventricles. Right ventricle pressure and volume overload is associated with septal displacement toward the left ventricle. Septal displacement, which can be visualized on echocardiography, is an additional factor that decreases left ventricle filling and output in the setting of cor pulmonale and right ventricle enlargement. Several different pathophysiologic mechanisms can lead to pulmonary hypertension and subsequently to cor pulmonale. These pathogenic mechanisms include the following: pulmonary vasoconstriction due to alveolar hypoxia or blood acidemia. This can result in pulmonary hypertension, and if the hypertension is severe enough, it causes cor pulmonale. Anatomic compromise of the pulmonary vascular bed secondary to parenchymal or alveolar lung disorders. Emphysema, pulmonary thromboembolism, interstitial lung disease, adult respiratory distress syndrome, and rheumatoid disorders. These conditions can cause elevated pulmonary blood pressure. Chronic obstructive pulmonary disorder is the most common cause of cor pulmonale, and some connective tissue disorders with pulmonary involvement may result in pulmonary hypertension and cor pulmonale. Increased blood viscosity secondary to blood disorders, increased blood flow in pulmonary vasculature, idiopathic primary pulmonary hypertension. Functional classification of pulmonary hypertension modified after the New York Heart Association function classification according to the World Health Organization. Class 1, patients with pulmonary hypertension but without resulting limitation of physical activity. Ordinary physical activity does not cause undue dyspnea or fatigue, chest pain, or near syncope. Class 2, patients with pulmonary hypertension resulting in a slight limitation of physical activity. They are comfortable at rest. Ordinary physical activity causes undue dyspnea or fatigue, chest pain, or near syncope. Class 3, patient with pulmonary hypertension resulting in marked limitation of physical activity. They are comfortable at rest. Less than ordinary activity causes undue dyspnea or fatigue, chest pain, or near syncope. And class 4, patients with pulmonary hypertension with inability to carry out any physical activity without symptoms. These patients manifest signs of right heart failure. Dyspnea and or fatigue may even be present at rest. Discomfort is increased by any physical activity. Signs and symptoms of cor pulmonale. The clinical manifestation of cor pulmonale are generally nonspecific. The symptoms may be subtle, especially in early stages of the disease, and they may be mistakenly attributed to the underlying pulmonary pathology. Fatigability, dyspnea, or exertion, syncope, chest pain, palpitation, abdominal edema or distension, lower extremity edema. Signs and symptoms. Angina chest pain can also occur maybe due to right ventricle ischemia or pulmonary artery stretching, which typically don't respond to nitrates. A variety of neurologic symptoms may be seen due to decreased cardiac output and hypoxemia. Hemoptysis can occur due to rupture of a dilated or atherosclerotic pulmonary arteriole. Other conditions such as tumors, bronchiectasis, and pulmonary infarction should be excluded before attributing hemoptysis to pulmonary hypertension. Rarely, the patient may complain of hoarseness due to compression of the left trigeminal laryngeal nerve by a dilated pulmonary artery. In advanced stages, passive hepatic congestion secondary to severe right ventricle failure may lead to anorexia, right upper quadrant abdominal discomfort, and jaundice. In addition, syncope with exertion, which may also be seen in severe disease, reflects a relative inability to increase cardiac output during exercise with a subsequent drop in the systemic arterial pressure. Elevated pulmonary artery pressure can lead to elevated right atrial, peripheral venous, and capillary pressure. By increasing the hypostatic gradient, it leads to transudation of fluid and accumulation of peripheral edema. A decrease in glomerular filtration rate and filtration of sodium, as well as stimulation of arginine vasopressin by hypoxemia, may play important pathophysiologic roles in this setting and may even have a role of peripheral edema in patients with Cor Pulmonale. Right ventricle hypertrophy is characterized by a left parasternal and subexifoid hair, hepatojugular reflex, and pulsatile liver are signs of right ventricle failure with systemic venous congestion. In severe disease, ascites can also be present. Diagnostic consideration. Once a diagnosis of Cor Pulmonale is made, it should be followed by further investigation to determine the underlying lung pathology. Sometimes a common lung disease, such as chronic obstructive pulmonary disease, is not the only lung pathology causing Cor Pulmonale. Other lung disease may coexist. Thus, pulmonary function tests may be required to confirm the presence of other lung pathologies. Ventilation perfusion scanning or chest computed tomography scanning may be performed in the patient's history, and physical examination such as pulmonary thromboembolism as the cause of other diagnostic tests don't provide a specific etiology. Imaging studies may show evidence of underlying cardiopulmonary diseases, pulmonary hypertension, or left ventricle enlargement. Cardiac magnetic resonance imaging is another form of non-invasive imaging that does not use ionizing radiation. CMR can be used to evaluate Cor Pulmonale, and it's useful in determining left ventricle structure, remodeling, and function. This modality is especially useful in accessing pulmonary artery dimensions when compared to traditional echocardiography. A general approach to diagnose Cor Pulmonale and to investigate its etiology starts with routine laboratory tests, chest radiography, and electrocardiography. Echocardiogram gives valuable information about the disease and right ventricle function, as well as assisting in determining the etiology of pulmonary hypertension and Cor Pulmonale. Laboratory investigations are directed toward defining the potential underlying etiologies as well as evaluating the complications of Cor Pulmonale. In specific instances, appropriate laboratory studies may include the following: hematocrit for polycythemia, which can be a consequence of underlying lung disease, but can also increase pulmonary arterial pressure by increasing viscosity. Serum alpha-1 antitrypsin deficiency is suspected. Antinuclear antibody level for collagen vascular disease and anti-SCL 70 antibodies is scleroderma. Calculation studies to evaluate hypercoagulability stages. Arterial blood gas measurements may provide important information about the level of oxygenation and type of acid-base disorder. Brain natriuretic peptide is peptide hormone that is released in response to volume expansion and the increased wall stress of cardiac myocytes. BNP helps to promote diuresis, natriuresis, vasodilation of the systemic and pulmonary vasculature, and reduction of circulating levels of endothelin and aldosterone. As a result, both congestive heart failure due to left ventricle failure and Cor Pulmonale due to non-cardiac pulmonary hypertension can lead to elevations in plasma BNP. Also, non-specific severe acute decompensated left ventricle heart failure can result in higher levels of BNP. Chest radiography. In patients with chronic Cor Pulmonale, the chest radiograph may show enlargement of the central pulmonary arteries with allogenic peripheral lung fields. Pulmonary hypertension should be suspected when the right descending pulmonary artery is larger than 16 millimeter in diameter and the left pulmonary artery is larger than 18 millimeter in diameter. Right ventricle enlargement leads to an increase of the transverse diameter of the heart shadow to the right on the posterior view and filling of retrosternal airspace on the lateral view. These findings have reduced sensitivity in the presence of kyphoscoliosis or hyperinflated lungs. Such ECG changes may include the following: right axis deviation, RS amplitude ratio in V1 greater than 1, RS amplitude ratio in V6 less than 1, P pulmonale pattern, S1 Q3 T3 pattern, and incomplete right bundle branch block, especially if pulmonary embolism is the underlying etiology. Low voltage QRS because of underlying COPD with hyperinflation. Echocardiogram findings: right atrial and ventricular hypertrophy, flattening of interventricular septum, small left ventricle dimension, dilated PA, pericardial effusion, Poor prognosis sign, array pressure, so high in impedance impedes a normal drainage from pericardium. Don't drain usually does not induce tamponade since right ventricle under high pressure and non-collapsible. Computed tomography. Main pulmonary artery diameter measurements more than 29 millimeter have a sensitivity of 84% and a specificity of 75% for the diagnosis of pulmonary hypertension. There are data to suggest then an enlarged main pulmonary artery diameter and ratio of segmental pulmonary artery diameter to corresponding bronchus diameter less than 1 increases the specificity of pulmonary hypertension diagnosis. Cor Pulmonale Management. Medical therapy for chronic cor pulmonale is generally focused on treatment on the underlying pulmonary disease and improving oxygenation and right ventricle function by increasing left ventricle contractility and decreasing pulmonary vasoconstriction. However, the approach might be different to some degree in an acute setting, with priority given to stabilizing the patient. Cardiopulmonary support for patients experiencing acute cor pulmonale with resultant acute right ventricle failure includes fluid loading and vasoconstrictor administration to maintain adequate blood pressure. Of course, the primary problem should be corrected if possible. For example, for massive pulmonary embolism, consider administration of anticoagulation thrombolytic agents or surgical embolectomy, especially if circulatory collapse is impending. Consider bronchodilations and infection treatment in patients with chronic obstructive pulmonary disease and consider steroid and immunosuppressive agents in infiltrative and fibrotic lung disease. Oxygen therapy, diuretics, vasodilators, digitals, theophylline, and anticoagulation therapy are all different modalities used in the long-term management of chronic cor pulmonale. Oxygen therapy. With cor pulmonale, the partial pressure of oxygen is likely to be below 55 millimeter Hg and decreases further with exercise and during sleep. Oxygen therapy relieves hypoxemic pulmonary vasoconstriction, which then improves cardiac output, lessens sympathetic vasoconstriction, right tissue hypoxemia, and improves renal perfusion. In general, in patients with COPD, long-term oxygen therapy is recommended when the pressure of oxygen is less than 55 millimeter or the O2 saturation is less than 88%. However, in the presence of cor pulmonale or impaired mental and cognitive function, long-term oxygen therapy can be considered even if the pressure of oxygen is greater than 55 millimeter or the oxygen saturation is greater than 88%. Also, the impact of oxygen therapy on survival in patients with cor pulmonale due to pulmonary disorders other than COPD is unclear. It may provide some degree of symptomatic relief and improvement in functional status. Therefore, oxygen therapy plays an important role in both the immediate setting and long-term management, especially in patients who are hypoxic and have COPD. Diuretic agents. Diuretics are used in the management of chronic cor pulmonale, particularly when the right ventricle filling volume is markedly elevated in the management of associated peripheral edema. These agents may result in improvement of the function of both and right and left ventricles. However, diuretics may produce hemodynamic adverse effects if they are not used cautiously. Excessive volume depletion can lead to a decline in cardiac output. Another potential complication of diuresis is the production of a hyperkalemic metabolic alkalosis, which diminished the effectiveness of carbon dioxide stimulation of the respiratory centers and lessen ventilatory drive. The adverse electrolyte and acid-base effects of diuretic use can also lead to cardiac arrhythmia, which can diminish cardiac output. Therefore, diuresis, while recommended in the management of chronic cor pulmonale, needs to be used with great caution. Vasodilators have been advocated in the long-term management of chronic cor pulmonale with modest results. Calcium channel blockers, particularly oral sustained release nifedipine and diltiazem, can lower pulmonary pressures. Also, this agent appear more effective in primary rather than secondary pulmonary hypertension. Beta-selective agonists have an additional advantage of bronchodilator and mucociliary clearance effect. Right heart catheterization has been recommended during initial administration of vasodilators to objectively assess the efficacy and detect the possible adverse hemodynamic consequence of vasodilators. Prostacyclin analogies and receptor agonist. Epoprostenol, treprostinil, and bosentan prostacyclin analogs and have potent vasodilatory properties. Epoprostenol and administered intravenously. Is administered intravenously. Treprostinil can be administered for and subcutaneously. The FDA has approved oral and inhaled formulations. Iloprost is commonly inhaled but requires frequent dosing. Bosten and macitentan are mixed endothelin A and endothelin B receptors antagonists, whereas embryosintol and a selective endothelin A receptor antagonist. Endothelins are peptides that act via vasoconstriction. Thus, endothelin receptor antagonist indicated results in subsequent vasodilation. The endothelin receptor antagonists and indicated in idiopathic pulmonary artery hypertension as well as pulmonary hypertension secondary to connective tissue disorders. Common side effects include elevated liver function, test findings. Phosphodiesterase type 5 inhibitors. By preventing the degradation of cyclic GMP and subsequently prolonging the vasodilatory effect of nitric oxide. Of these sildenafil has been intensively studied and was approved by the FDA for treatment of pulmonary hypertension. Sildenafil promotes selective smooth muscle relaxation in lung vasculature. There are not enough data available yet regarding the efficacy of these drugs in patients with secondary pulmonary hypertension, such as in patients with COPD. Guanylate cyclase stimulators. Riociguat is a soluble guanylate cyclase stimulant that mimics the function of nitric oxide as well as acts synergistically with it to promote vasodilation. Cardiac glycoside agents. The use of cardiac glycosides such as digitalis in patients with Cor Pulmonale has been controversial, and the beneficial effects of these drugs is not as obvious as in the setting of left heart failure. Nevertheless, studies have confirmed a modest effects of digitalis of the failing right ventricle in patients with chronic Cor Pulmonale should not be used during the acute phases of respiratory insufficiency when large fluctuations in levels of hypoxia and acidosis may occur. In addition to bronchodilatory effects, theophylline has been reported to reduce pulmonary vascular resistance and pulmonary arterial pressure acutely in patients with chronic Cor Pulmonale secondary to COPD. Warfarin. Anticoagulation with warfarin is recommended in patients in high risk of thromboembolism. The beneficial role of anticoagulation is in improving the symptoms and mortality in patients with primary PAH has been demonstrated in several studies. Thrombolytic therapy is indicated in patients with acute Cor Pulmonale due to a pulmonary embolism resultant and hemodynamic instability. In some cases, thrombolytic therapy may be indicated in patients with severe right ventricle dysfunction without resultant hypertension to prevent further decompensation. Surgical management of Cor Pulmonale. Phlebotomy is indicated in patients with chronic Cor Pulmonale and chronic hypoxia causing severe polycythemia, defined as hematocrit of 65% or more. Phlebotomy results in a decrease in mean pulmonary artery pressure and decrease in mean pulmonary vascular resistance. Pulmonary embolectomy is indicated in patients with acute pulmonary embolism and hemodynamic instability when thrombolytic therapy is contraindicated. Catheter-directed embolectomy can be accomplished with a variety of modalities, including suction embolectomy, rotation embolectomy, and rheolytic embolectomy, which involves the injection of pressured saline and concurrent aspiration of the macerated thrombus. Surgical embolectomy may also be indicated in similar patients or in patients whose previous thrombolytic therapy failed, particularly if the location of the thrombus is in a more proximal location. Respiratory failure. It's a syndrome in which the respiratory system fails in one or both of its gas exchange function, oxygenation and carbon dioxide elimination. Hypoxemic respiratory failure is characterized by an arterial oxygen tension lower than 60 milligram Hg with a normal or low arterial carbon dioxide tension. This is the most common form of respiratory failure. Hypercapnic respiratory failure is characterized by a pressure CO2 higher than 50 millimeter Hg. Hypoxemia is common in patients with hypercapnic respiratory failure who are breathing room air. The pH depends on the level of bicarbonate, which in turn is dependent of the duration of hypercapnia. Acute hypercapnic respiratory failure develops over minutes to hours, therefore pH in less than 7.3. Chronic respiratory failure develops over several days or longer, allowing time for renal compensation and an increase in bicarbonate concentration. Therefore, the pH usually is only slightly decreased. The distinction between acute and chronic hypoxemic respiratory failure cannot readily be made on the basis of arterial blood cases. The clinical markers of chronic hypoxemia, such as polycythemia or Cor Pulmonale, suggest a long-standing disorder. Respiratory failure can arise from an abnormality and any of the components of the respiratory system, including the airways, alveoli, central nervous system, peripheral nervous system, respiratory muscles, and chest wall. Patients who have hyperperfusion secondary to cardiogenic, hypovolemic, and septic shock often present with respiratory failure. Ventilatory capacity is the maximal spontaneous ventilation that can be maintained without development of respiratory muscle fatigue. Ventilator demand is the spontaneous minute ventilation that results in stable PaCO2. Normally, ventilatory capacity greatly exceeds ventilatory demand. Respiratory failure may result from either a reduction of ventilatory capacity or an increase in ventilatory demand. Ventilatory capacity can be decreased by a disease process involving any of the functional components of the respiratory system and its controller. Ventilatory demand is augmented by an increase in minute ventilation and or an increase in the work of breathing. Symptoms and signs of hypoxemia: dyspnea, irritability, confusion, somnolence, fits, tachycardia, arrhythmia, tachypnea, cyanosis. And symptoms and signs of hypercapnia: headache, change of behavior, coma, arthritis, papilloedema, warm extremities. Respiratory failure may be associated with a variety of clinical manifestations. However, the non-specific and very significant respiratory failure may be present without dramatic signs of symptoms. This emphasizes the importance of measuring arterial blood gases in all patients who are seriously ill or in whom respiratory failure is suspected. Chest radiography is essential. Echocardiography is not routinely done, but is sometimes useful. Pulmonary function test, if feasible, may be helpful, also more useful in terms of defining recovery potential. Electrocardiography should be performed to evaluate the possibility of a cardiovascular cause of respiratory failure. It also may detect dysrhythmias resulting from severe hypoxemia or acidosis. Right side heart catheterization is controversial. The following investigations are needed: Arterial blood cases is mandatory to confirm the diagnosis of respiratory failure. Chest radiography is needed as it can detect chest wall, pleural, and lung parenchymal lesions. Investigation needed for detecting the underlying cause of the respiratory failure. This may include complete blood count, sputum, blood and urine culture, blood electrocytes and thyroid function tests, pulmonary function tests, electrocardiography, echocardiography, bronchoscopy. Once respiratory failure is suspected on clinical grounds, arterial blood gas analysis should be performed to confirm the diagnosis and to assist in the distinction between acute and chronic forms. This helps assess the severity of respiratory failure and helps guide management. Chest radiography is essential in the evaluation of respiratory failure because it frequently reveals the cause. However, distinction between cardiogenic and non-cardiogenic pulmonary edema is often difficult. Increased heart size, vascular redistribution, peribronchial coughing, pleural infusion, septal lines, and peripheral pipeline distribution of infiltrate suggest hydrostatic edema. The lack of these findings suggests acute respiratory distress syndrome. Patients with acute respiratory failure generally are unable to perform pulmonary function tests. However, these tests are useful in the evaluation of chronic respiratory failure. Normal values for forced expiratory volume in 1 second and forced vital capacity suggest a disturbance in respiratory control. It decreases in the FIV1 and FVS ratio FVC ratio indicates airflow obstruction, whereas a reduction in both FIV1 and FVC and maintenance of V1 FVC ratio suggest restrictive lung disease. Right side high catheterization remains a controversial issue in the management of critically ill patient. Invasive monitoring probably is not routinely needed in patients with acute hypoxemic respiratory failure, but when significant uncertainty about cardiac function, adequacy of volume sedation and systemic oxygen delivery remain. Right sided heart catheterization should be considered. Treatment. Oxygen therapy to increase blood oxygen levels. Mechanical ventilation if oxygen therapy is not sufficient to increase blood oxygen levels. Tracheostomy. First-line therapy generally includes a loop diuretic such as furosemide. Nitrates reduce myocardial oxygen demand by lowering preload and afterload. In severity hypertensive patients, nitro-proceed cause more arterial dilatation than nitroglycerin. Tracheostomy, a hole made in the front of the neck to help you breathe. Nitrates reduce myocardial oxygen demand by lowering preload and afterload. Nevertheless, in view of the possibility of cyanide toxicity and the coronary still phenomenon associated with nitroproceed, forced nitroglycerin may be the initial therapy of choice for afterload reduction. Morphine 4 is an excellent and used adjunct in the management of acute pulmonary edema. In addition to anxiolysis and analgesia, its most important effects in venodilation, which reduced preload. It also causes arterial dilatation, which reduces systemic vascular resistance and may increase cardiac output. The principal inotropic agents are dopamine, dobutamine, inaprinone. Amplinon and milrinone inhibit phosphodiesterase, resulting in increased intracellular cyclic adenosine monophosphate and altered calcium transport. Bronchodilators are an important component of treatment in respiratory failure caused by obstructive lung disease. These agents act to decrease muscle tone and in both small and large airways in the lungs. This category includes beta-adrenergic, methylxanthines, and anticholinergics. Complications from respiratory failure may be a result of blood gases disturbance or from the therapeutic approach itself. Example of these complications: lung complications, cardiac complications, neurological complications, renal, gastrointestinal, nutritional. Thank you so much for your attention. Goodbye.